In the next few minutes, I am going to talk about a very simple technique, and that's why it's named chopping made to conquer brunescence and cataracts. It's a simple, easy technique. I think lots of people have already started doing this, and why I say simple now. Before that, we all know that brunescent cataracts are hard with a shiny brown reflective surface, and they typically have a thin capsule, little cortex, and of nucleus, a thin epinucleus, a fine or inner nucleus, and a very hard amorphous center. That is the central core of the nucleus, the hardest part of the lens. Well, the essence of modern phacoemulsion surgery is to disassemble the nucleus of the crystalline lens and emulsify the small pieces within a very safe environment, so that we do not interfere with the structural integrity of the other parts of the eye, and of course we minimize the collateral damages. Now, as for chopping in brunescent cataracts, we have really heard a lot of methods already exist, and some of which we have already seen. Since the time of Gimbel's concept of nucleopractice techniques, variations in nuclear divide technique has come up, like stop and chop, how Dr. Bhattacharya has just shown us, a wonderful technique, phaco chop, and many others. But we now know that vertical chopping is the method of chopping, and for hard cataracts, because as Dr. Mohta had described, we do not really have any softer part in that nucleus. So we need to go for vertical chopping in all cases of hard cataract, but then we need to remember one thing, that conventional techniques of chopping still remains challenging for brunescent cataracts in the truest sense. Let us begin with the video. Actually, this is just to emphasize a prerequisite. A large capsulorhexis is required, as Dr. Bhattacharya has just told us, that a large capsulorhexis actually facilitates maneuvering the large nucleus and also bringing out the pieces. Well, large means at least 5 to 5.5 millimeters in a big pupil, and of course a good hydro procedure, a good fluid wave should run through, and we should tap the center so that the fluid is it's released from the posterior part, because there is a large nucleus in the back. It's a huge nucleus, and after that we need to rotate the nucleus very well so that chopping can be done properly. So these are two basic requisites: a large rhexis and a good hydro procedure with good nucleus rotation. These are real basics to begin with. And now let's go into it. We impale the nucleus with the phaco tip, and then with the sharp chopper, vertical chop is made, thereby to initiate cracks in the peripheral part of the nucleus. You can see with the sharp chopper, I am creating little cracks in the peripheral part of the nucleus, and this process is repeated 5 to 6 times at least. These cracks actually are created in the periphery. They do not extend to
Therefore, a highly you can see at the end of 1 year also a straight line very close to zero. This is again something which is true for high myopia, which is not the same with when you use an excimer laser. But what is most attractive is this potential for minimally invasive treatment, and I would like to demonstrate a small video here. The same cornea, now we are applinating, and this is the first pass, again same like what I showed before. The second pass is more anterior, separated from the first one by the amount of refractive error correction required. But unlike the first video that I showed you here, it is ending as only a very small incision, through which you can now separate that particular lenticule and also remove it. The separation is very easy. This is the anterior one that we separated from the overlying stroma, the posterior one now, which you need to separate from the underlying stromal bed. And once you have the entire lenticule free of any attachments above or below, you can very easily just grasp it at the edge and remove it. And as you can see, it comes out very easily. You don't need to go and wash in the interface. And that small incision, which was initially 5, has come down to 3 and now routinely 2. And we are trying for a sub 2 millimeter incision also. Advantages, lot of them. No risk of flap displacements, there are no flaps, so no flap related issues at all. Small incision also means that you are cutting out minimally the corneal nerves and therefore less dry eyes. Again, something that bothers you with a LASIK procedure. Very little discomfort for the patient for a very small period. So if you compare it with PRK, where the biomechanical strength is also achieved to the same level, you would find that here the vision recovery is equivalent to what you get with a LASIK, but without the flap, and the strength of the cornea remains preserved vis-a-vis PRK procedure, but without the pain. So it's actually incorporating the best of both worlds and giving you a fantastic procedure with extremely good results and now proven over 5.5 years. And this again comes with very little induction of aberration, as you saw Dr. Sri Ganesh also pointed those out. We compared in 25 patients, one eye femto-LASIK, the other eye SMILE in the high myopic group above 6 diopters, and this is what we found. So you can imagine it's similar errors, same patient, same wound healing response. And this is what you can get. If you look at the point spread function, the SMILE one has a much better point spread function than as compared to the femto-LASIK one. And image simulation also SMILE scores better than the femto-LASIK. What is most important is that you get a true 6mm zone if you have aimed at one, as compared to a femto-LASIK done with an excimer laser, and therefore it gives you much better stability and a much better profile in terms of the refractive error correction. There is also workflow improvement, so you don't need to take the patient from one station to the other. You can do it within the same femtosecond laser. It also has a very nice microscope attached to it with a slit lamp attachment. So it's very easy to find those planes and dissect them. And in a study we conducted, SMILE took an average of 12.9 minutes for both eyes, including the patients coming in and lying on the bed and going out, while a femto-LASIK took an average of 21 minutes. A great saving of time, especially for some of you I know here are doing very high volumes. Patient acceptance. Patients really like this idea of not having a flap, not having pain, and not having any surface procedure done with slow visual recovery. So in my experience, Relax is an easier sell to patient than even a femto-LASIK. What about the cost? Most of the times you would find that when there is an increment in the technology, it also comes with a great increment in cost. Here it is, in fact, the other way around. Instead of buying 2 lasers, you need only one. And consequently, you have only to invest in one. So the capital, the consumable and the maintenance cost is also of only one laser. So does that mean that we throw away or dispense off with our excimer laser? No, we still need them right now for those very rare cases where we still need to do wavefront guided procedures. For doing retreatments, right now we are still dependent on the excimer laser, and hyperopic studies are on, but today, at present, we need to use our excimer laser. So maybe it's very soon going to be a time to say goodbye to excimer. Thank you.
Thank you very much, Dr. Rupal. Any questions for Dr. Rupal?
What are your results for cylinder treatment, toricity?
The toricity we've treated up to -5 diopters, and with the modern software, the pure spherical error treatments are also at par with the femto-LASIK treatment.
Pure cylindrical.
Pure cylinder.
Yeah, you said pure spherical.
Oh, sorry. Pure cylinder.
The zone that you treated, it's almost like 6mm per Relax. Whereas for the ablation zone in femtosecond for cylindrical treatment, it's like 8.5mm. So
No, you are getting mistaken here. In excimer laser and over here also, you will choose the zone that you want to treat.
Okay.
And we fed in the same zone in both ends. So we fed in 6 mm as the lenticule diameter in the smile line and a 6 mm in the control LASIK in terms of optical zone. Okay? So in both you should expect the same area, right, of the correction or the flattening that you are aiming at. But you saw the difference. And this is because in an excimer laser, because it's a round that is falling and at a curvature, you are going to have some losses of energy, as well as you need to actually do a transition zone because the zone that is getting created is not regular. So the transition zone is a necessity to be done in an